عليكم. عايزين نتكلم النهاردة عن specific points عشان نقفل شارت كويس للبيشنت بحيث ان هي تبقى up للregulations بتاعة الauditing بتاعة الانشورنس كومبانيز، ما يبقاش فيها اي مشاكل في الشارتس. فهنمسك بوينت لكل patient visit. اول حاجة البيشنت بيجي، اول حاجة عندنا في الشارت اللي هي التشيف كومبلين. التشيف كومبلين ما ينفعش نحطها كلمة ونسكت، عايزين نعمل detailed analysis للبيشنت complaint, onset, offset, duration, frequency, aggravating, precipitating factors. مش لازم يبقى perfect analysis للcomplaint، بس at least نحط حاجة تبين ان في دكتور يتكلم مع البيشنت دون. دي simple straightforward، مفيش اي حاجة هتتعمل فيها. بعد التشيف complaint بنخش على النقطة بتاعت المedications. We have to make sure ان احنا نوقف اي acute medication البيشنت كان بياخده، سواء painkillers, muscle relaxant, antibiotics البيشنت خلصه. لازم نوقف اي medication البيشنت ما ياخدوش. لو البيشنت تعرف يجيب معاه الادوية بتاعته كلها هيبقى افضل ان احنا نشوف البيشنت بياخد ايه وما بياخدش ايه. لو البيشنت مش عارف الادوية اللي بياخدها، مش عارف الدوزج، مش عارف هو ماشي على ايه او مش ماشي على ايه، في ال ECW في ال RX window حاجة اسمها external RX history. ودي you have to get the patient's consent. After you get the patient's consent هنضغط على external RX history. Do you have the patient's consent? Yes. نضغط على الزرار بتاع RX eligibility. Check RX eligibility. المفروض ده test chart فمش هيعمل، بس لو real patient هيعمل RX eligibility وبعدين نضغط على set formulary. بينزل لنا ليست بالميديكيشنز كلها، سواء الميديكيشنز دي البيشنت اخدها من عندنا في العياده او اخدها من اي دكتور تاني. الميديكيشنز dispensed من اي pharmacy under any doctor's name. نراجعها نشوف لو الليست دي فيها ادويه البيشنت لسه بياخدها هنزودها على الميديكيشن ليست. البيشنت ما بياخدهاش هنجست discontinue. بعد ما نفيريفاي الميديكيشنز مع البيشنت لازم نعلم على كلمة verified. تعليم على كلمة verified دي بينزل جملة في الشارت بتاعت البيشنت إن the medication has been reconciled and verified with the patient. This is very important when they're auditing us إن هم يتأكدوا إن إحنا راجعنا الأدوية مع البيشنت، especially لو patient عنده أدوية كتير diabetic و hypertensive high risk patient. They're gonna audit all of this. بنخش بعد كده على past medical history. يا ريت كل مرة نراجع ال past medical history. البيشنت ممكن يكون جد عليه حاجة هو ما قالهاش. Don't take it for granted إن البيشنت قال لك ال past medical history إن أنت عرفتها خلاص add it to the chart. البيشنت غالبا بنسبة 99% هيشوف حد غيرك المرة الجاية. بعد ما بنزود ال past medical history هندوس على history verified، وكذلك ال allergies. لو البيشنت complained من allergic reaction من any medication please add it, and then we press allergies verified. نروح بعد كده على surgical history. surgical history برضه لو في أي حاجة significant هتضاف. surgical history verified هندوس عليها. hospitalizations دول most probably مش هيغيروا كتير أوي بالنسبة للبيشنت. hospitalization verified. نروح على family history. mostly mother or father alive ولا deceased. لو في history of diabetes, hypertension, malignancies هنعلم عليهم ونضغط على family history verified. social history. social history ECW deletes every year social history من patient's chart. So you have to take social history from the patient if he doesn't have it. If you can take it every time, do so. أهم حاجة tobacco use, patient smoker or non-smoker. Sexual history is very important, especially for teenagers. Even if they're Arabs, even if they're Muslims, take sexual history because you could find something in the sexual history. Drugs and alcohol. Drugs is very common. Marijuana, pot, any other drugs. Please try to document it. Alcohol screen. Don't be shy that the patient is Muslim, is Arab, to ask him if he's drinking alcohol or not, because surprisingly some of them do. And then you mark on social history verified. Review of systems. التابلت دي ما فيهاش اي حاجه. هنروح بعد كده على vital signs. نحط vital signs عادي خالص. لو patient teenager try to make sure as much as you can ان انت تاخد weight and height every time because they grow and you're gonna find difference in weight and height each visit the patient comes. هنيجي بعد كده للتابلت بتاعت الاكزامينيشن. We must try as much as we can ان احنا نغير في الفيزيكال اكزامينيشن بتاع البيشنت. انا مش بقول ان احنا نلفق اكزامينيشن للبيشنت، بس you cannot have a chart that says that the patient is complaining of low back pain, lower limb edema, palpitations, the patient is atrial fibrillation and his heart rate is regular, lower limb edema, and then in the examination says no lower limb edema. Try and do a related physical examination as much as you can. If there are findings, try to put the findings. Patient complaining of an abscess, describe in the examination where is the abscess, what's the size of the abscess, redness, swelling, anything in the skin. Patient complaining of lower limb edema, 1+, 2+, pitting, non-pitting edema, bilateral, unilateral edema. Patient has a diagnosis of otitis externa. He cannot have a physical examination that the ear is normal, external auditory canal. Try to change at least one physical examination related to the patient. When we come to the assessment, this is very important. Each and everything, every disease, every patient complaint you can think about has a specific ICD-10 code. Try to use as much as you can a different ICD-10 code for each complaint. Don't depend on putting chronic complaints. Patient diabetic, hypertensive, knee osteoarthritis. If he comes with a new complaint, include the new ICD-10 code even if it's acute. Do not just include chronic complaints 3 to 5. If you run out of complaints, you can add after that the chronic complications along with the assessments, but you have to use a specific ICD-10 code each time. Remember, please, each and every patient complaint, each and every disease has a specific ICD-10 code that must be used and documented in the patient's chart. Okay, last thing, the treatment. This is extremely important. For the treatment, put each and every medication under the patient's assessment. Please do not just put type 2 diabetes and include 15 medications under that has nothing to do with diabetes. eClinical Works has something called eClinical Sense, which you can refill medications based on patient's disease. And we have this messed up because we put each and every medication under unrelated assessments. So each and every medication has to go under the appropriate assessment, especially that when you send this prescription, it goes with the ICD-10 code to the pharmacy. And everything that we do has to make sense, especially when we get audited for the charts. There are some specific forbidden medications that no one is allowed to send without Dr. Amin's approval. دي مش غلاسة من العيادة. Because these medications most probably are very expensive, require prior authorization, and there are perfect alternatives for these medications. Some medications like the metformin extended release, omega-3, Migranal, capsaicin cream, lidotril cream, butalbital acetaminophen, Linzess, Creon, Zenpep. And the reason is that most patients do not have any problems and are taking Creon and Zenpep. They don't have pancreatitis, they don't have any related disease that they should be taking this for. So it's just we're preventing abuse of medications, not more. Other than that, everything's fine. These medications, there is a list for these medications in each and every room. They cannot be sent without Dr. Amin's approval. The last tablet is the CDSS, and these are the preventive measures that you should ask the patient about. Try to document in the chart that you ask the patient about these. Let's say you referred a patient to do a screening mammogram. There is a specific ICD-10 code for screening mammogram. Use this ICD-10 code and write in the chart referral for screening mammogram. Also for the colonoscopy, there is an ICD-10 code for screening for malignant neoplasm of the colon. Use the ICD-10 code, write in the note that the patient has been referred for the colonoscopy. Each and every preventive measure has its own ICD-10 code. We have to document that we discussed that with the patient. Most patients, when they show up, we keep asking them each and every time if they did this, if they did that, because we are not documenting the date, whether the patient did it or not. Did we give a patient for referral for this or not? And did we discuss it with the patient or not? This is going to make the visit shorter, more convenient for the patients, because they get fed up when you keep asking them each and every visit about the same thing, because you don't know whoever came before you asked the patient or not. So certain preventive measures are extremely important for diabetics: eye exam, foot exam, A1C, microalbumin, and at least ABI once for screening of peripheral vascular disease. Hypertensive patients, they should do ABI at least once a year. Patients with asthma should do pulmonary function test every 6 months. Any patient less than 24 years old should do urine test for screening for chlamydia and gonorrhea. Check the vaccinations: flu vaccine, pneumococcal vaccine, herpes zoster virus vaccine, and we have a code for the preventive, which should be done every year. And this is basically what we do in each visit with the patient when we ask him if he did the colonoscopy, if the woman visited the GYN, if he did this, if he did that. We should report the preventive code once every year. So we'll start with this. To report the preventive, you have to put 2 choices from the templates. First choice is the PE and then the patient's age, and you have 3 choices for that. So we have PE from 12 to 17, 18 to 39, and 40 to 64. According to the patient's age, you choose just one only, and then you go up and put the second template, which is the annual, and annual is divided male and female, and each according to his age. One more thing for the BMI for kids, less than 18 years, we do not report the Z code for the BMI. They have a special ICD-10 code. You have from 5th to 85th percentile, 85th to 95th, less than 5th, more than 95th percentile. Any patient less than 18 years, you should report the BMI with one of these codes. You should put it on the chart, documented on the chart. You should refer the patient less than 18 years old for a dentist for an annual dental visit. Going to the templates, we have almost a template for each and every complaint that you most commonly see in the clinic. We have templates for acute sinusitis, allergic rhinitis, chronic prostatitis, influenza, URI, UTI, gastroesophageal reflux disease, IBS, low back pain, neck pain. Try before putting the template follow-up and review of systems. Ask the patient, wait until the patient tells you his complaint. Maybe his complaint is related to one of these templates, and you can use it and save time with changing the examination and changing. If you put like follow-up and review of systems, you have to change everything, so that these templates are gonna save you a lot of time. Then if the patient has any other additional complaints and there are any other assessments that could be done, you can add that later on the template. We have templates for medical clearance if the patient is doing a surgery, and there are 2 templates: preoperative evaluation and medical clearance. The preoperative evaluation includes the blood test and includes an ICD-10 code for preoperative evaluation. Put the ICD-10 code in the super bill. And the medical clearance itself, this after the blood test comes out and Dr. Amin clears the patient. In the complaint, when you put the template for the clearance, there is a space for the surgeon who's going to be operating on the patient, name of the hospital, date of the surgery, and what kind of surgery. please change these between the brackets. Do not send out a medical clearance that says patient is going to see doctor, between brackets, doctor's name, to do a between brackets procedure. It doesn't make any sense, looks very bad. Okay, and then we have counseling templates. We have counseling for BMI, overweight, underweight, hypertension, pre-hypertension, smoking cessation. Counsel the patient. Try to write a couple of words that you spoke with the patient about. If the patient is hypertensive and his blood pressure is high today and there was no change in the medications, please document why Dr. Amin didn't do any change in the medications. Did the patient not take his medication? Patient was compliant, non-compliant on his medications. He ran out of the medications. Because it doesn't make sense that you have a hypertensive patient that would come to the clinic with a blood pressure of 160 over 90 or 160 over 100, and he walks out of the clinic with the same medications. Well, if this shows up at the end, it would be considered malpractice. Even if the patient was non-compliant and you counseled him that he should take his medication, nothing proves that except the documentation that you do. Same for diabetics. You cannot have a diabetic patient with a hemoglobin A1C of 9.5 or 10 and walks out of the clinic without changing his medications. With diabetics, try to be more sensitive. They're more high risk, and the better we control diabetes, the better their prognosis, the better their outcome. So please take extreme care with diabetics when sending medications. Make sure that the patient did his blood test. Make sure that the patient did microalbumin. If microalbumin is positive, make sure that the patient is taking an ACE inhibitor or an herb. If he's not taking, ask the patient why he's not taking the ACE or the herb for the microalbumin. If his hemoglobin A1C is high and no change happened in his medications, document in the chart why there was no change in diabetic medications, because it does not make sense that you would get a patient with hemoglobin A1C of 12, walks out of the clinic without updating his medications, and he's taking the same doses. There must be a reason that you should document. So continuing with the templates, we have other templates like the Epworth scale for sleep apnea, obstructive sleep apnea. We have other templates for functional assessment, advanced directive, and pain assessment. Any person 66 years and above, you have to do functional assessment. Advanced directive, please ask the patient. Do not feel embarrassed. It might be a sensitive subject, but most patients are going to understand when you explain to them. Pain assessment, you ask the patient whether he has pain in this visit today or not. If yes, you press on pain assessment, yes, and it gives you in the HPI a template for analysis of this pain. If you press no, it's gonna say pain assessment no, the patient does not have pain, easy enough, that's it. You have PFT codes. If patient is doing PFT, you put the codes for PFT included on the super bill. Post-discharge visit, you don't have to include that template, but just any patient who had a visit to the ER or was an inpatient in a hospital, when he comes back, you have to use a code of 1111 for ones, which is a post-discharge medication reconciliation. It means that you reviewed with the patient the medications that he received upon discharge, the medications that they stopped for him, and you actually did that on the Super Bowl. We have a refusal templates, refusal of colonoscopy, diabetic eye, diabetic foot, refusal of flu vaccine, mammogram, pap smear. You do that if the patient refuses to do these services. Before you include the refusal template, try and speak with the patient, offer alternatives for the screenings, try and ask the patient why he is refusing these screening measures. Try to address the patient's concerns. If there is anything concerning him regarding the screening measures, If the patient still refuses, we have a refusal form that the patient should sign. We're going to include it on the patient's charts, and just let him know that if he decided at any time to change his mind and do these screening measures, he can come back at any time. Make sure at the CDSS window to press on the hand sign and then suppress until, let's say, 1 year, reason patient refusal. Because let's say the patient refuses to do a colonoscopy. Every time he shows up in the office, someone is going to ask him about colonoscopy. He's going to get furious. He's going to get angry. So you just want to avoid that. Just write patient refusal, make him sign the form, and that's it. After you make sure that you explain to the patient everything. When you ask the patient about alcohol, we have a template for screening for alcohol and depression, and the template just basically puts in the patient's answers for screening of alcohol. If it's no, if it's yes, you're gonna go back. So let's say we put the template for alcohol screening. In the social history, it's gonna give you alcohol. You're gonna press on details, and if the patient is alcoholic, yes. How frequently does he drink? When was the last time he overdrunk? These such of questions. The same for depression. You have two forms for depression, PHQ2, PHQ9. You start with the PHQ2. If screening is positive, you go to the PHQ9, and then you refer the patient to a psychiatrist if it was positive. That's pretty much it for the templates. Make sure to review patient's labs each and every time if you can. Don't depend that someone before you have reviewed the patient's labs, because most of the time this did not happen. So if you can take your time, check the patient's labs, anything abnormal, make sure that the patient already took the medication for that. If the patient needs to do another labs, let him do it. Diabetic patients generally need to do hemoglobin A1C every 3 months. Maximum, you can leave the patient up to 6 months. More than 6 months, you never saw the patient. He needs to do microalbumin once a year. If you didn't do microalbumin once a year, you never saw this patient, these patients' labs, you never spoke with this patient. Lipid panel, 3 to 6 months. Hypertensive patients, complete metabolic panel, urine analysis, and blood test every 6 months. For the medications, one more time, it's extremely important that you review the patient's medications. Stop the medications that the patient is not taking. If you do not stop the medications, if you do not reconcile the medications 3-4 visits later, you're going to end up with a patient medication list that is 30 or 40 medications big. If you had the time to get the external RX history, get the external RX history from ECW. Put each and every medication under the patient's assessment. For diabetics and hypertensive patients, do not send medications haphazardly. Each and every time you send medications for diabetics, their refills build up in the pharmacy. So let's say you send today metformin with 3 refills. The patient comes next week for something else, and you send him another prescription for metformin 3 refills. The patient got 6 refills. And then 1 week later, the patient comes, you send him another prescription for metformin with 3 refills. The patient got 9 refills. Most probably, this patient is not going to do blood test for 9 months. This is how we end up with diabetic patients not doing blood tests for over a year, and they're still getting their refills from us, because most probably this patient has an accumulation of 12 to 15 refills in the pharmacy, and this is totally non-acceptable. All of these regulations are for the best interest of the patient. And remember, anything not documented, no one knows you did it. No one knows that you reviewed anything. So unless you document it on the chart, then it's not done.